So these are my disclosures. So I think that we have seen over the years that transplant has become an increasingly used modality of treatment for patients with MDS, as we have accessed more reduced intensity conditioning based transplants, which have therefore allowed older patients who make up the majority of patients diagnosed with MDS to actually proceed to transplant. But as you can see from these two retrospective studies, on the left from the EBMT and on the right from the CIBMTR, you can see that the major problem, the major cause of treatment failure for allogeneic stem cell transplant for MDS is that of relapse, with significant proportions of patients succumbing to relapse, at least 30%, if not slightly higher. So in terms of trying to optimize transplant for MDS, really, I think I will focus in this talk mainly on the disease itself and how we can try and control this. So, as you, I'm sure, would expect, there are essentially several points where disease control in MDS is relevant and would have an impact on transplant outcome. So we have the pre-transplant disease status and treatment, what the role of conditioning is, and finally prevention of relapse post-transplant. And all of these separate stages are impacted upon by factors such as patient selection and fitness, disease risk stratification, donor availability and selection, preventing NRM, and supportive care such as microbiome interventions, which are increasingly being explored. So I won't be focusing on the wider areas, which are more cross-cutting, but on these specific areas. So I'll start by talking about pre-transplant disease status and treatment, and essentially how much disease control pre-transplant, how much does that affect outcomes? So I think over the years there's been some debate, and this continues to persist, about how much cytoreduction is essential prior to an allogeneic stem cell transplant for high-risk MDS in order to improve outcomes. And these are some data which were published back in 2019, and this was a retrospective analysis of 165 patients with MDS EB or secondary AML, and looked at their outcomes according to their treatment pre-transplant. So around 40% had had upfront transplant, a similar proportion induction intensive chemotherapy, and then about 20% had HMA-based treatment prior to transplant. And in terms of the blast percentage, the upfront patients all had more than 5% bone marrow blasts, and then the intensive chemotherapy patients, 59% had achieved CR, and with HMA, 18%. So when you look at their outcomes, you can see that according to these data, so even taking patients with upfront disease, no treatment, and more than 5% bone marrow blast, their outcomes seem to be similar to those patients who underwent both either intensive chemotherapy or HMA with similar relapse-free survival. So these data suggested that perhaps for these patients with MDS and an increasing blast, maybe control of the disease and cytoreduction was not essential. However, there have been other studies which have contradicted this. And for example, in this retrospective study from the States, and if you also look at the currently still existing ELN 2017 guidance for MDS patients, you can see that where there were patients who had less than 5% blast proceeding to an allogeneic stem cell transplant, and this was even predominantly in a myeloablative setting, there was a higher cumulative incidence of relapse for those patients with 5 to 20% blast, although in this study the p-value was 0.07, so not significant. But essentially, prospective data are still somewhat lacking in this area, and the ELN 2017 recommendations still suggest debulking to fewer than 10% bone marrow blast prior to transplant to improve the outcome. So the question then arises as to how we should cytoreduce in high-risk MDS pre-transplant. And as I've already alluded to, there are very few randomized control studies that have been published. One such study which is currently recruiting is the ACROBAT study, which is from Gitmo in Italy, from the Italian group. And this is a phase 3 randomized control trial, which is looking at what happens to patients who receive HMA and go to transplant versus upfront transplant. So this is only for patients with fewer than 10% bone marrow blasts. And if they have higher than 10% bone marrow blasts, they are randomized either to HMA or intensive chemotherapy. So that could be an interesting study for us to learn from, and the results are awaited. And then the question should also be, what are the objectives of cytoreduction? So what are we aiming for in these patients? It's somewhat different from acute myeloid leukemia, you might argue. We could reduce the blast percentage to below 5 to 10%, but exactly how low? We could reduce mutational burden. We could even go so far as to trying to reach an MRD negative state. But how much will this influence the outcome? And what would be the challenges and toxicity of trying to achieve such deep response? We might also be looking to try and reduce marrow cellularity in these patients who are often hypercellular, but we also often want to improve or control the disease burden whilst a donor is being identified. And certainly cytoreduction could be more relevant in the context of reduced intensity conditioning versus myeloablation. But given the majority of patients will undergo reduced intensity conditioning, perhaps it's something that we really do need to understand better. And there are potential disadvantages for proceeding to cytoreduction, including failure of therapy, and perhaps then a patient becoming deconditioned or having resistant disease and ultimately not reaching transplant. Of course, we may, with our chemotherapy pre-transplant, select resistant clones within the MDS, which then cause problems post-transplant. And we know that you do accrue complications and side effects with many of the drugs available to us, such as fungal infections or cardiotoxicity, and these may be more so with intensive chemotherapy, although even some of the non-intensive approaches can cause considerable problems. So what studies are there that have looked at debulking pre-transplant in high-risk MDS? So these are a few of the retrospective, mainly registry studies of a single centre, which have looked at the impact of the pre-transplant intervention, usually either intensive chemotherapy or HMA, on the relapse-free survival and overall survival. And when this type of analysis has been done, essentially most of these studies have not shown any clear difference for either approach. And of course, it is difficult with registries to understand exactly why a particular treatment was chosen by the physician. There are many biases which could be occurring. So therefore, what about prospective trials of debulking pre-transplant? And there have been some of these, although they are generally somewhat difficult to conduct. If we look at the first study, which was carried out in the States, unfortunately, this had to be terminated due to low accrual, but was looking at patients who are MRD positive with AML or MDS EB2, who are MRD positive following induction, and then looked at either taking them to transplant or having further CPX351. Alternatively, there are some other studies. The second one is not yet reported that I could find, which was looking at HMA versus intensive chemotherapy in MDS CMML with EB 5 to 20%. Then there are a couple of ongoing studies, ACROBAT, which I've also mentioned already, and Paloma, which is a German-Austrian collaboration and is looking at oligoblastic AML, so including MDS EB2, effectively, and looking at the role of CPX351 for up to 2 cycles versus either DA or HMA prior to transplant. What we do have are some data from this clinical trial, which was a prospective clinical trial led by Nicholas Kroger. And this was a German study that was actually geared to looking at the role of treating patients either with 5-azacitidine or with transplant. So the question was not specifically about the type of induction pre-transplant, but it's possible to draw some important pieces of information from this study. So these high-risk patients by IPSSR all commenced azacitidine, and then responders after 4 cycles were randomized to transplant if a donor was available or to continuous azacitidine. And whilst there was an event-free survival benefit for patients who went to transplant, there was no overall survival benefit for transplant. The CR rates were only about 14% overall, and there were several PRs, and stable disease was also very common in 50%. But the important point to note was that there was a very high dropout rate of about a third of patients who either died or progressed during cycles 1 to 4 of azacitidine. So equally, if we do decide to give pre-transplant treatment, we should be aiming to get to transplant as soon as we are able, because we may lose patients on the way. And then if we think about our current standard of care, at least in the UK and in several countries around the world, the standard of care remains HMA, so azacitidine, as a treatment for high-risk MDS. And we know that the response rates are both short-lived, and only about a third of patients will respond. So, and in terms of CRs, the CR rate will be lower. Therefore, many groups and drug companies have tried to look at what the impact of adding another drug to HMA backbone would have on improving responses in high-risk MDS. And as I'm sure many of you will be aware, sadly, this has been a graveyard over the years with no real advance and several drugs falling by the wayside. So in terms of ongoing phase 3 trials looking to improve on azacitidine, I think we are all still eagerly awaiting the results of Verona, which is randomizing venetoclax and azacitidine versus azacitidine in treatment-naive high-risk MDS. We also await the phase 3 for Stimulus, looking at the role of sabatolimab, and currently progressing is tamibarotene, which has reached the point of interim analysis. And there's another study, Ascertain, looking at the role of the oral decitabine cedazuridine compound, ASTX727. So we still have some hope, although history unfortunately has not proven favourable for high-risk MDS. So what data do we have for the role of venetoclax in high-risk MDS pre-transplant? There has been a phase 1b study whilst we await the results of Verona, and data were presented at ASH last year. And you can see that these patients were adult de novo patients, 107 patients treatment naive with high-risk MDS, IPSS score at least 1.5 or IPSS greater than 3, with less than 20% blasts at baseline, who went on to venetoclax given 400 milligrams orally daily on days 1 to 14 per 28-day cycle with azacitidine. And there certainly have been promising results reported for this combination, with a overall response rate of 80%, including CR and marrow CR as well as PR. And the median number of cycles that patients had was 4, and the median time to CR was around 3 months, suggesting that this can work quite quickly to get patients into a good remission, and noting that this was quite a high-risk population group, so 86% had high or very high-risk IPSSR and 90% had more than 5% blasts. Median duration of CR in months was 16.6, and about 40% proceeded to transplant. So, as I mentioned, we await the results of Verona, which again uses the same schedule of 14 days of venetoclax for both transplant eligible and ineligible patients, and it will be interesting to see the CR and OS from these rates from this study, and the rates of movement to transplant in those who are eligible. So if we continue to understand again how important the depth of disease control is pre-transplant, and if we accept that fewer than 5% bone marrow blasts are preferable according to the ongoing practice, ELN 2017, etc., data suggests that we should be trying to get the bone marrow blast down, then the question then remains is how deep should the remission be? And obviously in AML, MRD has become increasingly a utilised modality and is now starting to guide treatment decisions, but less so as yet in MDS. And this is a study which was one of the earlier ones to look at the role of what they called minimal identifiable disease by either cytogenics or FISH, or by flow cytometry. And what you can see is essentially that there is more separation here in the curves for the reduced intensity condition patients. And so there is a suggestion that perhaps, at least in certain, with certain conditioning types, and probably with certain types of disease, that the depth of disease control could be relevant. And subsequent to that, we've seen much more detailed and precision-based analysis by looking at the role of NGS MRD. So this study from Chris Hurrigan's group has looked at in patients undergoing transplant within the BMT CTN 0901 phase 3 trial of conditioning intensity in MDS. This looked at pre-transplant blood samples from MDS patients who had fewer than 5% bone marrow blasts, so 48 patients that were studied, and 42% of the patients had mutations detectable on their pre-transplant sample. And if they were positive, then they had a significantly increased rate of relapse, so a 3-year relapse rate of 40% versus 11%. And decreased overall survival. And certainly there appeared to be an impact of conditioning on this, in that there was a lower rate of relapse for the NGS MRD positive MAC patients, myeloablative patients, versus RIC. So I think over time, as the technology advances and as we learn more about it, the use of MRD and understanding better the degree of disease control required will help to guide our strategy to improve our post-transplant outcomes. What about conditioning, and how does conditioning intensity affect relapse-free survival in high-risk MDS? So essentially, the two studies that have provided us the most information on this topic have been the US study led by Scott, the BMT CTN 0901 that I already mentioned, and then Kroger study, which looked at MAC versus RIC in a European multi-center study. And the two studies were somewhat different. They included different patient groups. And then in the MDS patients, these tended to be a much smaller subgroup of the whole population, particularly in the Scott study. And therefore, it was underpowered to specifically address outcomes for the MDS group. There were differences in the choice of MAC and RIC conditioning across the two studies, and they had different primary endpoints, which means it is somewhat difficult to completely extrapolate between the two. Although the Scott study essentially suggested that the patients who received a MAC had superior outcomes compared to those patients who received a RIC transplant. But pointing out that the TRM was very low in that study, at 16% for a myeloablative transplant, 4% for a RIC, and was higher and perhaps more, as we are used to, in the Kroger study. So all of these factors could be affecting the outcomes. The longer-term follow-up of the CIBMTR study confirmed the original findings, and it does seem likely that higher intensity might be necessary in higher risk patients based on some of the NGS data I've also shown you, but a caveat may remain P53 mutated disease. However, in the UK, we carried out a study called Figaro, which looked at an augmented RIC regimen, looking at the use of Flamzabu ATG RIC compared with standard of care RIC in patients, again, with AML and MDS, so MDS being a subgroup within the AML population. And this study did not find any difference in overall or event-free survival for the use of an augmented RIC regimen, although there were some interesting findings about the potential for conversion to full donor chimerism to overcome MRD positivity and its impact pre-transplant. And so there are other studies that are also pending, including COSY, which is another UK study which is a phase 3 randomization between the use of TBF versus fludarabine busulfan-based conditioning in patients that includes a group with MDS with high risk. So the results of that are also awaited. And there are currently recruiting studies of novel conditioning regimens listed here. This is just a selection. And of course, venetoclax is being combined with our standard chemotherapy drugs in some of these studies, but there are also other studies looking at a range of well-known options and trying to evaluate them against each other. The last study at the bottom is not so much a conditioning study, but it is a formal randomized evaluation comparing the role of ATG plus cyclosporine and MMF as graft versus host disease prophylaxis versus a PT-side-based regimen in patients undergoing matched unrelated donor transplant. And this is called MOTD and will include some patients with fewer than 10% bone marrow blasts. So finally, in the last section, how can we actually try and prevent relapse? And how can we identify those patients who are at the highest risk of relapse? So we know that the IPSS-M itself could better predict transplant outcomes than the IPSS-R. We know that from the original data set that the IPSSM was developed in, and in a real world validation of the IPSSM in 964 transplant patients, 204 were upstaged by the IPSSM and 229 were downstaged, and the IPSSM was significantly better at predicting overall survival and relapse-free survival than the IPSSR, although you can see that there's still some degree of lack of separation at the bottom of that curve on the right. We know also that monosomal karyotype independently predicts for poor outcome following transplant, with dismal long-term survival of around 10% and very high risk of relapse. And therefore, identifying some of these patients who we know will do particularly poorly will either suggest that we should have aggressive strategies to prevent relapse post-transplant, or perhaps suggest to us that transplant will be futile. And this is where perhaps the discussion around P53 comes in, although there remains some controversy here as well. So these data from Coleman-Lindsley from back in 2017 were some of the first to really show us that patients who had P53 mutation, whether they were young or old, whether they had a RIC or a MAC transplant, did very poorly, with a 3-year overall survival post-transplant of only 20% surviving, and a median overall survival of under a year. And there are other gene mutations that were identified in that study, including RAS and JAK2. And we know that P53 mutational state is complex, and it's not just whether you have or don't have P53 mutation, but is this a monoallelic or a biallelic abnormality? And as I'm sure you will be aware, that there is clear definition as to the TP53 multi-hit state, and trying to understand whether someone has monoallelic disease, or whether based on both karyotypic and or also gene mutational changes, whether someone has either a single hit to their P53 or more than one. And Elsa Bernard's data now from back in 2020 demonstrated the adverse survival for MDS patients with a multi-hit state, whereas those patients with wild-type disease appear to have perhaps a similar outcome as the mono-hit patients. However, there have also been other studies looking at the impact of P53 status, and these have not necessarily shown a difference in the same way for single versus multi-hit. Either way, we know that this is often associated with complex karyotype, for example, or other adverse prognoses, such as monosomal karyotype. So if we're going to try and intervene with patients post-transplant, we need to have better ways of trying to identify disease occurrence early, because once patients' disease is returned, we know that their chances of long-term salvation, salvage goes down considerably. And so these are some retrospective studies that have looked at MRD monitoring post-transplant for high-risk MDS. And essentially, they have tended to use different modalities. So in the top study, multi-flow cytometry, the Dunkervage study from published in NEJM in 2018 looked at NGS. And Nakamura more recently published the use of a personalized ddPCR assay to monitor patients undergoing transplant. And essentially, all of these studies have shown that pre-transplant MRD can be associated with positive MRD can be associated with relapse. And secondly, that there are that having MRD positivity early on post-transplant is associated with higher risk of disease progression or death. And so there are several studies now that are showing that MRD could be predictive. And so this is another study that has also demonstrated that prospective monitoring of MDS, NGS, MRD post-transplant can be carried out, and actually by identifying at different thresholds. So in the study on the left, you can see the level of MRD detected at 0.1, 0.3, or 0.5 will stratify patients as to their risk of their relapse-free survival. And similarly, the incidence of relapse significantly goes up is significantly observed in these patients with high MRD. And in terms of MRD is the most important predictive factor in that particular study for relapse. There are other factors which are also important, such as P53. And so there will be interaction between some of these, but clearly we are perhaps reaching in the coming years an ability to use detailed and sensitive MRD tests to help predict and maybe enable intervention. In terms of maintenance post-transplant for high-risk MDS, there are a few studies that have been published, including some randomized phase 3 studies and a phase 2, looking at azacitidine maintenance and APR 246, but so far none of these clinical trials have shown benefit. And there are some other studies that have looked at drugs such as enasidenib, venetoclax and azacitidine, and ivosidenib in phase 1, but we need to await randomized studies. And the oral azacitidine maintenance option has been evaluated in a clinical trial called Amadeus, which is a phase 3 randomized controlled trial looking at azacitidine versus placebo in high-risk MDS patients going to transplant, and will read out next year. What about the role of DLI? I will touch briefly on this. So DLI plus or minus some sort of chemotherapy has been used for either prevention of relapse using chimerism as a surrogate marker, or for treatment of relapse. And certainly our own study, I show the data from our single center published back in 2013 at the bottom. On the left, this data shows the effect of using preemptive DLI in patients with MDS or AML, 62 patients, using CD3 chimerism to guide administration of DLI, resulting in excellent overall survival of 80% and a 65% 5-year event-free survival. And based on these promising findings, we have carried out the PRO-DLI clinical trial led by Dr. Victoria Potter at this institution, and this randomized patients with MDS and AML to either early weaning of immune therapy and prophylactic donor lymphocyte infusion, regardless of chimerism results, versus a preemptive DLI strategy based on mixed myeloid chimerism. And the data from that should also be reading out most likely next year. So to conclude, I think in terms of how we can improve outcomes for these patients, we need to better understand the need for cytoreduction pre-transplant for high-risk MDS patients, and we need to understand what we're aiming for when we do this, for a marrow CR, for MRD negativity, for more than that. And then standardize MRD monitoring and incorporate this as potentially as a clinical trial endpoint. We need to optimize pre-transplant treatments and look at novel agents, and also improve patient selection according to disease risk, which at present is controversial. For example, considering the utility of transplant for P53 or very adverse monosomal karyotype disease. For conditioning, we should await the results of prospective trials such as COSY and consider novel conditioning regimens, which include new agents such as venetoclax. And there's still a question mark over the role of sequential conditioning, but perhaps identifying the right situation to deliver that in. And finally, prevention of relapse. We need to better define disease monitoring pre and post-transplant. So rather than surrogates such as chimerism, but actually have personalized specific disease monitoring that can give enough warning of relapse for time to intervene. We need to be able to risk stratify pre-transplant better and then personalize the post-transplant plan accordingly, and use strategies such as early withdrawal of immune suppression where possible, and the possibility of preemptive or prophylactic DLI to prevent relapse, perhaps with or without maintenance. And with that, I thank you for your attention.